Good afternoon, everyone. My name is Ritika Thapa. I'm one of the faculties here at Yale. I'd just like to make some brief housekeeping announcements before I introduce our today's speaker. Please take a moment to ensure that you are muted. In order to receive the CME credit for attendance, please see the chat room for instructions. And if you have any questions or comments during the presentation, please use the chat room or just unmute yourself at the end of the talk, and you can ask the questions on your own, and I will also moderate the session in the end. Now, without further delay, I would like to introduce our today's speaker. I have the pleasure of introducing Dr. Ashima Shani today. She received her medical degree from Government Medical College and Hospital in India. She then completed her internal medicine residency and pulmonary critical care fellowship from Cook County Hospital in Chicago, where she was also a chief resident. And then she completed her sleep medicine fellowship from Northwestern University, Chicago. She's currently an assistant professor of medicine, University of Illinois, where she's also the assistant program director for sleep medicine fellowship. Her interest has primarily focused in non-invasive ventilation. She has developed the NIV clinic at University of Illinois and is involved in various workshops, curriculum development, postgraduate courses, and national meetings and task forces related to it. She's also lectured in courses in sleep disorders nationally and especially related to NIV. She's received many awards and has also authored many publications. She's held leadership position in many national societies and is very much involved in fellows mentoring. Thank you so much for being with us, Dr. Shani. And without any further delay, I would like to hand it over to you to share your expertise on this really complex topic of interpretation of various NIV downloads.
Um, Thank you so much. Thanks, Sri, for your wonderful introduction. Thank you. That's very humbling. And Today, I would want to talk about interpretations of NIV downloads. It's a dense topic. I'll try to be very slow, and feel free to interrupt, ask questions, and then I think maybe Shri is. Should we keep the questions to the end? How do you want to? Okay, so we'll keep the questions to the end. Please feel free to put them in your chat. And I think the recording will be available, and feel free to, and I'll share my slides with Sri, so in case anybody wants to look into that. So without further ado, this is my disclosure slide for everybody. There's nothing to disclose on my end. So objectives for today's discussion is basic understanding of the various variables that we employ looking at the downloads for these home mechanical ventilators, and then troubleshooting. So I'll have some case discussions at the end just to wrap up things as we go by. So this is kind of a snapshot, and it's pretty impressive for me that from where we started and where we have ended. So in the beginning, it was CPAPs and how the download started coming along with that. And then since 1995, we started having implementation of monitoring software, which has slowly and slowly evolved into coupling of physiological data with NIV. And 2010 beyond, we are able to have cloud monitoring on our home mechanical ventilators. So it has come a long way from where we started in 1985 to where we are right now. Just basic understanding about the long-term domiciliary mechanical ventilation or non-invasive ventilation. So as we all know, they are divided into two big categories. On one side, we have the respiratory assist devices, and on the other side, we have the life support machines, which are our home mechanical ventilators. I just put the coding for that, just for everybody to be on the same page. So when we are talking about respiratory assist devices, we have our E0470 for the spontaneous, and then the backup rate with 71. As we all know, Philips recalls and all that has changed the market dramatically. So right now, as far as the RADs are concerned, the ResMed is out there, and Luna is coming up with their VAPS technology. And Brius has the VAPS technology outside US. It should be coming to United States at some point. Now, looking at the home mechanical ventilators, there are a bunch of them out there. You have the Astros that you might all be familiar with. We have the Voxens. Louisa is pretty new on the block. Then we have Brius. And this is our trilogies, which we'll see them around for some time, but will probably be obsolete soon. Now, as far as the FDA supports only asynchronous data access for our RAD devices and for our home mechanical ventilators. And there is an FDA requirement that we cannot remotely change anything on the home mechanical ventilators, but we can do that on our RAD devices. So I just wanted to put it out there for everybody to be on the same page. Now, just some basic, so that we are all well versed with the terminology. So when you're talking about basic bilevel pressure waveforms, you have your IPAP and EPAP, and based on the pressure support, you're able to maintain a tidal volume. There is some complexity to it, but we'll just leave it that to the basic thoughts. When you're looking at the bilevel, spontaneous versus timed, you can see the timed breaths are machine breaths. There is a fixed TI time which will come along with it. The spontaneous breaths are when you'll get the assured pressure support, but the tidal volumes might vary depending on the area under the curve and how much TI time will be required. Now, when we add VAPS, which is an add-on modality for your ST or your pressure control mode, you can see that the ceiling or the roof both can move based on whether auto EPAP has been added as well or not. So you have your EPAP and you have an IPAP. So the machine will try to shoot for the targeted volume that you have set in, and based on that, your ceiling will move. And if you have additional auto EPAP on it, your basement can also move to make sure the upper airway is patent and you are getting an assured tidal volume. So those are the few terminologies I want to make sure everybody is well aware of. Okay. So now I just put this slide out there for everybody to be aware of what all ventilators are on the market and how things will change. And like we are in the transition, so the post-Philip era is what I'm calling it right now. So you have all ResMed Astrals. They all have the VAPS. Most all the ventilators right now have the VAPS mode. The AE mode, the Voxens don't have it, but it's available on everything else from ResMed to Trilogy, Louisa, and Vivos. The remote monitoring capability is present in all of them except for Louisa right now. You need to use a USB for it, but if my information is correct, it is coming out pretty soon. And as you can see, most of these have pretty similar circuit options, so there's not much variation that will happen. And as I mentioned before, the RADs, which have the VAPS technology, we still have the ResMed STA, which is still AirCurve 10. It hasn't been introduced in AirCurve 11 yet. The Luna came out recently, and Brios, they have it, and hopefully we'll get it at some point. So just to understand the circuits that I mentioned, usually we talk about the double lumen circuit when patients are usually trached. So this is, you have an expiratory and an inspiratory limbs to it. But when we are talking about non-invasive ventilation in general, we are using the single limb circuits. So I just want to make sure everybody understands that. So you have a ventilator. This is technically your inspiratory arm. And over here, you can either have an exhalation valve or you can have the vented circuit over here with the exhalation ports on the mask. And those are the two other ways that you will be using your circuits for your home mechanical ventilator or your RADS device. Okay, so now the goals for non-invasive ventilation. So the only society guidelines that I could find which actually enlists the goals of non-invasive ventilation are the Swiss Society that came out with it in 2020. So they enlist that the aim for us to have non-invasive ventilation is to have clinical improvement in the patient and have reduction in the daytime PCO2, also with some improvement in their hypoxemia usage for more than 4 hours without any discomfort, and then correction of nocturnal hyperventilation, which kind of goes synonymous with the improvement in your daytime hypercapnia. But as we have practiced and evolved, our expected goals in my head are patient comfort, which is again translated into reduced work of breathing, diaphragm rest, restful sleep, achieving our goals, which are the target tidal volume and minute ventilation based on the physiology that pathophysiology that we are dealing with, reduction in atelectasis and excessive dead space associated with low tidal volumes, reversing the hyperventilation, and maximizing the quality of life. Uh, but if we look at the evidence behind telemonitoring, since it is pretty new and it's still evolving, there is lack of sufficient data. There are smaller studies out there which are looking into reliability, acceptability of telemonitoring. So I'll just briefly show you some of the studies that I encountered which enlist the benefits of it. So the first study actually talks about reduced cost per year. This was a prospective controlled trial for 40 patients done in UK, and it showed that you are able to save almost 700 pounds per patient per year, based on what all benefits can come, whether it was reduced ER visits, whether it was reduced equipment cost, either way. They didn't list that in totality. The second one was a study published in 2015, which said you can predict respiratory exacerbations just by looking at the patterns about their tidal volumes or the respiratory rate. So you could predict their COPD exacerbations, basically. And the third important one was reduced ER visits and inpatient admissions with a trend towards improved survival. So this was a study that was done in a small group. It was a prospective study looking at 39 patients with ALS. And they looked at a combination of usual care versus usual care plus telemonitoring. And this was a pretty old study. It was published in 2010. The newer study that was done in France, which just got published last year, is the STEL-VENT study, which is a pretty extensive study, and I wish we can replicate something similar in United States. But in this particular study, there was an interaction between the patient, the medical team, and a home healthcare provider. And there were alarms and alerts set in the telemonitoring, which would alert the nurse and which will look at the download, who will go through it, see if there are any changes in the pattern, reinforce education. And in the whole study that was published, the most important thing that came out was if you look at day 15 versus 6 months, 12 months, 18 months versus total population, new NIV setups, they slowly went up. The usage for more than 4 hours also went up in this whole study arm. I'm not going into the details about the study, but feel free to read it. It's pretty interesting. It just got published last year. So now just switching the gears and talking about the VAPS download interpretation, since we went through some of the evidence behind it. So as we discussed, it's available in RADS. It does not have auto EPAP in United States yet in our RADS devices. It probably, if word on the street is accurate, it's probably coming out sometime soon in RADS as well. But obviously, we have the home mechanical ventilators which have that. So when you're looking at the download, there are two types of variables that you would be seeing. The first type is the directly reported variables that the machine is just getting it. The second one is calculated. And there is a lot of variability comes when it's calculated. So the directly reported variables will be more accurate, which is the usage, the delivered breath rate, the patient-initiated breaths, the TI time, inspiratory flow rates, and your expiratory and peak inspiratory pressures with the pneumotac that they're using. The calculated by the device will be your tidal volumes, leaks, AHIs, and minute ventilation. So looking at the, I think I missed once. Okay. So looking at the reliability of these NIV download variables, the first one is the leak. So there was a study, a bench study that was done, which showed the leaks were reliable in most of the ventilators that they had studied. The tidal volumes, not so much, because there was significant difference in the accuracy between the ventilators with significant leaks when they're happening. The rate and the backup rate, they don't know how some of these ventilators account for double triggering. So the accuracy, they're not very sure of. But since these events are less, they think the respiratory rate will be pretty accurate when it comes to the downloads. What we don't know is the percent patient triggered breaths that come on your download. What's the accuracy of that? Because it has never been studied. So in nutshell, when you're looking at accuracy, decent accuracy is there definitely for the hours that I talked about. The respiratory rate, total leaks. So this is important. It's the total leaks, not the intentional, unintentional leaks. And then your TI time and the I to E ratio. Acceptable are unintentional leaks and the AHIs. And then suboptimal are the tidal volumes and your minute ventilation. I hope I'm not going too fast for everybody. Okay, I saw Siri saying something. Okay. So when you're looking at the download, the step one is to understand each and every variable that is listed on the download so that we have a better understanding. So the first thing that comes, this is an STA device, a RADS ResMed that I'm showing you for reference. So the first thing you look at is obviously the adherence, how much patient is using it, because that kind of gives you a framework of what you might have to troubleshoot eventually. The second is obviously the most important thing for me is the target alveolar ventilation. And I don't know how many times the height is not accurately entered. The targeted patient rate will not be accurately entered. So for everybody to know, the IVAPS calculator is now available online. So you just have to type in IVAPS calculator. I have made it a practice that every time a patient comes in, I put those numbers in just to get my alveolar ventilation. And it has changed some of my things, but for everybody knows. So this is how you'll be putting the height in, your preferred input about your ml per kg, the targeted patient rate, and your then you put the calculator sign and you get the values. So you have to make sure that is accurately entered. And then the next page that you go to is your usage and then the leaks. So the leaks, as we all know, there will be total leaks that could be mentioned, or there could be unintentional leaks that will be mentioned. For now, everybody to understand, the intentional leaks are intended to be in the circuit so that you are washing out your CO2. The unintentional leak is what will come out if the mask is not fitting you properly or there is mouth opening that is happening. So ResMed devices usually mention the unintentional leak. Respironics and the Breus, the Vivo, they both will be mentioning the total leaks. And based on some of the studies that have been reported, so if you're looking at your ResMed device, you would want the median leak to be less than 10 liters per minute and the 95th to be closer to 24 liters. So anything beyond that will make your algorithm falsely inaccurate, and the calculated values will not be very accurate. When you're looking at the total leaks, obviously as the pressures go higher, the leaks will tend to be higher. So anytime you have a leak beyond 40 to 60, you have to take most of the calculated values on the download with a grain of salt. Now, as far as the second part of it is, I feel like this is a very important crux of it, where you get what the patient is actually doing based on the median, the 95th, and the maximum. So you get your IPAP and your EPAP measures. At that point of time, I always tell my fellows, look at your first page and make sure you have enough room in case there is an exacerbation or the patient, there's some amount of, you're not hitting the ceiling at any point of time. So that's when you have to look at your download and make sure you have some amount of room left in case you have to go up on your volumes at some point. Now, as far as the reliability of the AHIs, so there was a study published in 2015 that looked into it, and it came to a conclusion that there is sufficient to monitor these patients and look at the AHIs. Anytime it is below 10, I think you're in a good shape. But obviously, there were study limitations because it didn't look at the patients with neuromuscular or OHS or COPD. It just had looked at the patients with OHS at that point of time. So, and how the algorithms, obviously, the way the AHI is calculated is also different for each brand. And it is very proprietary, so we don't have access to all of that. But anytime the AHI is below 10, I think you're in a good shape at that point of time. So looking at the minute ventilation again, make sure you look back at the leaks at that point of time, because remember, minute ventilation is calculated just like the tidal volume is being calculated. The other thing we all usually practice over here is calculating the rapid shallow breathing index. There are very limited studies that have been done, very small ones, and it was more indirect evidence that came out. But usually, as we all do in ICU setting, we do the similar one in outpatient setting that you do it respiratory rate divided by tidal volumes in liter. Our goal is to keep it below 40 to 60. So if you're around that time, it does give you some reassurance that you are giving some amount of diaphragm rest and there is reduced work of breathing for the patients. Anytime those numbers are higher, then you have to figure out and troubleshoot where do I go up on the TI time? Do I need to go up on the pressure support? How to bring down that respiratory rate will be helpful. Just to show you how most of the home mechanical ventilator downloads. So this was the RADS device that I had gone through. Some of the other variables that will be mentioned on your home mechanical ventilator is obviously the mode that will come up. And remember, the HMVs have the auto EPAB feature. RADs don't have it right now in United States. It will come eventually. Then they'll always mention the circuit because obviously you can use that for tracheostomies and have invasive ventilation at that point. This mass interface is very important because remember, the way the tidal volumes are calculated and the way the leaks will be calculated will be dependent on the interface that has been put in. So if there is an inaccurate interface, your values will not be very accurate. And again, as I mentioned before, make sure the height is accurately entered because sometimes patients, especially the neuromuscular patients who cannot stand, their heights I have seen invariably entered erroneously. So in those situations, sometimes you want to just measure their arm and the wingspan and make sure there is some assessment to that if you cannot get them to stand. Uh, Now on your ventilators, you will also have, just as I mentioned, the TI min, TI max, and the auto EPAP settings. They will also have your trigger settings and your cycle settings. And for everybody to be on the same page, I just want to make sure they all understand that the trigger is the switch between the EPAP to IPAP. And the rise time is how quickly you want to transition from EPAP to IPAP, how quickly you want that. And then the cycle is switching off from IPAP to EPAP. And based on your pathophysiology or what disease you're dealing with, those numbers will change accordingly. Now, once you understand each and every variable, the next is to obviously verify the device and verify the prescription and make sure it's accurately entered. And the third is obviously to ensure that the download is adequate. So the first thing you will look up is your compliance on it, if it is more than 4 hours or not. If it's not, then you want to make sure what is the cause for it. Is it the leaks, the asynchrony? Is there a discomfort to that? Is there inadequate pressures of IPAP or EPAP, or the targeted rate is not accurate? So you have to look into all those things. But if the compliance is there, you look at whether the leaks were adequate or not. Obviously, if the leaks are not adequate, you're trying to resolve those issues, which I feel is always challenging. And sometimes these patients are just doing remote telemonitoring. So it becomes very challenging in those aspects. So there is a bit of combination that have to be used to try to get an adequate leaks. Then once leaks are adequate, you want to make sure you're achieving your goals of targeted tidal volumes. Most of the times it's close to 8 cc's per kg. Very rarely we'll be using close to 6 cc's in patients who have very restrictive physiology. Or you might go slightly higher to maybe 8 to 10 cc's for spinal cord injury patients. But usually your targets are close to 8 cc's. If you're not able to achieve the tidal volumes, then you want to obviously see if there is upper airway obstruction that is accounting for that, or your TI min is not accurate, or you need to go up on your pressure support at that point of time. So once this is dealt, then you obviously make sure the AHI is adequate, and less than 10 is the number that came out based on the study that I mentioned previously. If there is any other issues beyond this, then again, you want to go towards RT going to their house, or you bring in the patient to the to your clinic, either doing a bedside or considering a sleep study at that point of time if you're not able to achieve all this. But if you are, then you have an adequate download. The step 4 is to achieve the goals to making sure the hyperventilation is adequately controlled and your hypoxemia is getting better. So you can add on these therapies. Now there are ways of adding it on to your ventilators or just adding it on separately. So doing an overnight pulse oximetry, your spirometry, end-tidal CO2s or transcutaneous CO2s, or the transcutaneous, again, you can do it overnight or you can do a spot check in those situations. I didn't mention obviously the blood gas here, which will be which is the gold standard, but it's always hard to get it. Patients have contractures, they have transport issues, so end-tidal CO2s or transcutaneous become your go-to. End-tidal CO2s will be difficult with NIVs and masks, so the transcutaneous becomes your default at some point. As for the spirometries, again, either you do it in your clinic or they can do it remotely. There are a few devices that can transmit the data to you. I haven't used them, but it is out there. If somebody is interested, I can send them the links for that. Okay, since we went through all the variables and what each and everything means, we'll just dive into some of the cases just to make sure we have all the understanding we require. So the case 1 is a 44-year-old male who was recently diagnosed with limb onset ALS. has no bulbar symptoms currently. He complains of fragmented sleep due to orthopnea. So when we did the PFTs, his forced vital capacity was 71 and his MIP was 70. The overnight pulse oximetry had a mean saturation above around 89.7. But if you look at his blood gas, it was touch bit elevated with hypercapnia. So he qualified for his machine based on that. So the patient returns to the office for his routine follow-up, and he started complaining of increased morning headaches and needed 2 extra pillows to fall asleep on his back. So there was a bit of dyspnea that was worsening. So he was on AVAPS ST with a targeted volume of 450, EPAP of 5, min IPAP of 12, and a max of 25, and the rate was set at 16, and the VAPS rate was 3. So this is how his download looked like. So you have monthly ones over here. You can see it. This is from October, November, December, January, and February. The AHIs attained EPAP, attained IPAPs, breath rate, exhaled tidal volumes, leaks, patient-triggered breaths, and minute ventilation. So I'll give you some time to review that, and then what would be the best next step to help it? And feel free to raise your hand if you want to answer this, or we'll just go by. Should I give the answer, or is
Yeah,
somebody?
maybe you can give the answer. I don't see any hands or anything in the chat room.
Okay, sounds good. So the answer over here is mask fitting, and we'll go into the dissection of the download. So you can see that, as I mentioned, anytime the total leak is beyond 40 to 60, you have to take every other calculation with a grain of salt. So the leaks kept consistently going up, especially in January, February. So there was a large pressure leak, because of which obviously the IPAPs or the pressure support had to be increased to try to achieve the minute ventilation, but clearly that was going on. But since the patient had neuromuscular disease, the patient could not really increase the respiratory rate to increase his minute ventilation. So there was decreasing tidal volumes and low minute ventilation because of that. So once the mask fitting was done, these things got corrected and the patient was good. Okay, so changing some gears. So case 2, this was an inpatient consult that we got. She's a 34-year-old female with past medical history of morbid obesity. Her BMI, if I recall, was close to 45. Had prior diagnosis of OSA and was currently admitted with heart failure exacerbation. A blood gas in ED on admission, clearly acidotic with PCO2 of 66. We did find a record of a PSG done in 2020 when she required a BiPAP of 17/13. So before we were consulted, she was already put on a V30. That's what we still have in our hospitals. She was put on the same pressure settings that the sleep study had. So she was put on 17/13, as you can see here. I don't know if you're familiar with the V30s. We try to get some of these V30 downloads on a regular basis if we are initiating somebody on NIV in the hospital settings. So you can see IPAP and EPAP over here. And then you can see so these were the basic settings on that. And then the download showed an AH of 2.2. She was attaining the IPAP and the EPAP that we had set at, but exhaled tidal volume was slightly on the lower end, 261. And as you can see, there were pretty high unintentional leaks that were noted. So this was the download on her. So there was some improvement in the blood gas, but then the RT went ahead and did a mask fitting. And this is the download from the next day. So you can still see the BiPAP 17/13. I'll give you some time to look at the download from the next day. I'm not sure if the picture's too hazy. Seems like a bit. So just to recap, once the mask fitting was done, the leak was slightly better, but still slightly there. The tidal volumes did improve after the mask fitting. but the AHI went up dramatically. And if you look into the detailed download, it was more obstructive events than central events. I didn't put a snapshot for that. So what could have been the etiology for that?
Any of the fellows, you can feel free to put it in your chat. I think you should give the answer. I don't.
Okay, sounds good. So as we all know, the tighter the mask fits, sometimes this patient was initially put on full face mask. So you can, if the mask is fitting too tightly, you can have a bit of retrognathia, and that can also cause more of pseudo obstructions. And we suspected that was the case in our patient. So we eventually switched it over to a nasal mask. And otherwise, you can use a mask stabilizer also, which can help you in those situations. But remember, tight-fitting mask can also worsen your AHI. So the EPAP obviously was not adequate enough in that situation. So I was just trying to give you contrast that on the first case, the mask fitting was great, but then we overshot it and did a very tight-fitting mask, and that can also become a problem. And there have been a bunch of cases in our clinic that has become more of a chronic problem. I don't know if you guys have observed it, but we go from one spectrum to another spectrum very quickly. Okay, switching some gears, I just wanted to show you different downloads from different ventilators. So this is a trilogy download. So this is a case 3 of a 24-year-old patient with Down syndrome comes to us for establishing of care. So she has chronic respiratory failure from before based on the records, and she was started on a ventilator a couple of years ago and came to us to establish care. So as you can see, she was put on AVAP's AE from before and had a tidal volume set at 350 with the EPAP min and max of 5 to 14. And a pressure support pretty high from 18 to 25. We were not sure if the sleep study was done or these were random settings that were placed in. But you can see based on such high numbers, she had a significant tidal volume of 700. Her HCCs was close to like 350. And there was decent leaks because we were at such high levels. But as you all recall, the trilogy does not have an AHI, so we didn't have a reported AHI. But this was the crux of our first meeting. And this was a tele visit. The mother refused to come to the lab or to the clinic and get any blood gases done. So we were kind of stuck, and we ended up just doing an overnight pulse ox on this patient just to get some assessment of what else is, like, are we on the right track or what could be going on. So this is a snapshot which was done on the settings that I showed you. So I'll just give you some time to review that. So as you all can see, the ODI on your overnight pulse ox, I'm like, it was pretty significant, which I'm like, I sometimes do use that as a surrogate of AHIs when I don't have an AHI reported on the download. But if you look at the overnight pulse ox, you can see a pretty decent decrements that are happening. And it's a very REM predominant pattern with increase your pulse rate and all. So we suspected that in this patient, the AHI was probably not adequately controlled, though she was getting, like her hyperventilation was probably taken care of. But these decrements in the AHIs gave us an indication that there is some obstructive events which are still present, though she was on auto EPAP, if you all recall. So this was her download, just going back. So she was averaging at EPAP of 9, though there was a range of 5 to 14. So there was something that was preventing her. And if you can see that she had a decent leak. So when your leaks are high, the algorithm will fail invariably. And though her AHI was elevated based on the overnight pulse ox, the EPAP was not going higher because of that. So obviously, this is another way of looking at it. But the answer over here was, again, we decided to do a mass fitting. Things did get better. And an overnight pulse ox, I didn't put it for the interest, but if the overnight pulse ox did improve eventually. So this was a very good article, and I just want to show for all the fellows out there. It just got published last year from the same France group that had published the Telven study. If you look over here, this is a normal pulse ox that should look like with your ODI less than 5 and your time spent below 90% for less than 5% of your total sleep duration. This is usually how hyperventilation would look like. So obviously your mean saturation is above 90 and your ODI is less than 10, but the time spent below 90% is usually more than 5% of your total sleep time, or the total recording time. And if you have a VQ mismatch, which will predominantly show as hypoxemia, the mean saturation on the overnight will be much lower. You can see the nadir is pretty low. The ODS usually should be lower because there's not upper airway obstruction that is present. And the time spent below 90% will obviously be below much higher than 5% of your total recording time. And if you're looking at just upper airway obstruction based on your pulse oximetry, so your ODIs will be higher, though the time spent below 90% should be less than 5% because you don't have hyperventilation in combination. But if you combine your hyperventilation with your upper airway obstruction, you can definitely see a decrement. Your ODIs will be higher. Your time spent below 90% will be much more than 5% of your total recording time. So I find this article is amazing. It just got published a few months ago. It gives you a very good snapshot of overnight pulse ox, and it's very simply, beautifully written article. So please for all the fellows out there, please find time and read this. This is very informative for NIV standpoint. Okay. I don't know if anybody needs a breather. We are still heading on. I have 2 more cases to discuss. Hopefully we'll have time left for some of the questions at the end.
We have time.
Okay, that's good. So case 4, it's slightly more intense than what I had presented before. So this is a 32-year-old Duchenne muscular dystrophy patient who comes to our clinic to establish care. His ejection fraction on chart review was 25%, and he was started on a ventilator many years ago. And patient had recently started noticing worsening headaches and more sleep disruption, which prompted him to seek care and see a pulmonologist again. So I didn't have a download because we didn't know the DME, and also there was a bunch of things that had to be taken care of. But because of his symptoms, I preemptively, along with requesting a download, requested a transcutaneous CO2 monitoring with overnight pulse ox just to get a sense of where he is, because he was, again, 2 hours from Chicago, so it was hard for him to come by and for us to get things done. So just to give another flavor of the ventilator, so this is a Vivo 45. It's a Breus download. I'm not sure if you're familiar with them. Are you using them? But this is how those downloads look like in general. So you have a ventilator mode, and then this patient was on auto EPAP, you can see, and you have a min pressure support, a max pressure support. So most of the variables are pretty self-explanatory. So this is the settings on that patient when he came to see us. I'll just give you some time to look at them. She just give me a thumbs up when you have reviewed it so that I have a benchmark when to move to the next slide. Okay. So this was some of the variables. So as you all know, Breus Vivo downloads recently added the AHIs. It still doesn't show the minute ventilation or the respiratory rate, but they're improvising. Apparently, there's another upgrade to the downloads coming out in May. So we'll have more comprehensive downloads, which what we are familiar with for Astrals. So, but over here, you can see the usage was decent for that night, but his AHI was high. His leaks were higher. The peak average PEEP was 6, and a iPad that he was requiring was close to 13. But what really struck us, as you can see, this was a Centec overnight pulse ox and transcutaneous CO2 that was done on that night with those downloads. And the patient was pretty symptomatic, if you recall. So you can see this patient spent almost close to 8.5 hours above 50 of transcutaneous CO2. So he was hyperventilating, which is why he was pretty symptomatic. So oh, I gave you the answer here. Crap. I thought this was animated. So what went wrong? If somebody can give me some kind of synopsis, why this caused that problem? So if you see, I already put the box and gave up the answer there. The TI time was turned off. So this patient did not have a TI min or a TI max. So what was happening was he was having rapid shallow breathing. So if you look, if the detailed download had a respiratory rate close to 17. So the backup rate was not kicking, period, because the backup rate did have a TI time. So that never happened. And this patient continued to be in just pressure support mode without any TI time. So remember, whenever you're talking about neuromuscular patients, if it is in pressure support, it is flow, it will cycle off with your flow. So they are not able to generate enough tidal volumes when they are so weak. So this patient just used to go up and down probably very quickly. And there was no assured TI time because the TI time was turned off. And that was probably what was causing his problems. So this is just a nutshell of us to understand. So as you can see in spontaneous mode, there is variability with each and every breath because it's very effort dependent. It is flow dependent. That's how it will cycle off. When you have ST mode on, which was turned off in our patient because the time was off, you don't get that. So the solution to these problems will be either you turn on your TI time, give a TI min and a max, or you change over to pressure control. Because the pressure control, you will assure each and every breath has a TI time, though sometimes it is uncomfortable for the patients, but that is the way you can assure that the tidal volumes are there and the hyperventilation is getting better. Um, and in ResMed devices, I'm like, you can change over to pressure control, but usually with the TI min and TI max, that's what I'm trying to show you. You can simulate ST versus PC. So the TI, but the patient will be forced to reach the TI min, but it can cycle off between TI min and TI max based on your flow, but it'll be time cycle at the TI max. So it can push you, it'll definitely push you till TI min, but if your patient's effort is still continuing, it can go all the way up to your TI max. So that's how you can simulate between ST and PC. So in this particular patient on Brias, when we switched over to pressure control, so over here now you can see it's pressure control mode. He got a fixed TI time of 1.2 seconds. And though the leaks were still high, his time spent above 50 came dramatically down to 1 hour, which now I blame is because of the leaks. I need to still fix the leaks on this patient, but you can see that just by changing their mode and assuring a TI time, we almost went down from 8.5 hours to 1.5 hours of hypoventilation in this patient. So just be very mindful when we are looking at these downloads, what each variable means, because that dramatically changes how the patient will respond. And this one seemed to like the pressure control, but we are still working on the leak. So that will be my next thing, and that will hopefully improve his hyperventilation even further. So this is again a very good graph from the table from the article I was mentioning that got published last year. So this is normal transcutaneous CO2s. So you want to spend time below 50. And this is how hypoventilation will look like. So just remember, the green line is the raw measurements, and the blue line is usually corrected for the drift. So you want to look at the blue lines when you're looking at the Centec transcutaneous CO2s. So when you have patients with hypoventilation, obviously the time spent is above 50, and the change will be obviously between awake and nighttime, the variation will be more than 7.5. And also remember, since we are ventilating a patient, we can also hyperventilate, which can also be picked up by your transcutaneous CO2. This will be invariably missed on your overnight pulse ox because that will look great, but you're hyperventilating these patients. So in those situations, usually your transcutaneous will be below 35. Okay. Now switching gears, this is our last case. So I have a 67-year-old patient who came with a complex presentation because of idiopathic right chronic axonal loss phrenic nerve neuropathy in 2012 in the setting of retroperitoneal fibrosis. So the patient had developed chronic hypercapnia. The CO2s that time were 47, and the patient was started on a BiPAP in a spontaneous mode on 22/12 because, as you know, diaphragm paralysis, it's hard to get a backup rate on these patients, but she seemed to have done fine. There was some improvement over time, but her diaphragm was still paralyzed, so she was kept on BiPAP. So the download reviewed in 2023, she had a pretty decent compliance. Again, the leaks were slightly on the higher side, but as you go through the download, the AHI had gone up. And if you look at the breakdown, it was more predominantly centrals that were happening. And the median tidal volume was 611, based on also you can see the transcutaneous CO2 had gone down to 35. So what do you think led to the central sleep apnea in this patient? So this is just the breakdown that she was on 22/12. And you can see again, there are predominantly centrals that were happening. So we were almost overventilated. Did somebody mention? Yes.
Somebody said hyperventilation.
Yes. So we were hyperventilating the patient and blowing it below their apneic threshold. So in this patient, obviously, we ordered the mask fitting again. And because we were overventilating, we brought down the IPAP empirically. So as you can see in the next, the leaks were still a bit elevated, but the events did come down and the central index improved and the tidal volume also came down. And this was the nutshell. We didn't, our AHIs, the central events had come down. So there is always a flip side of whatever we do. These patients are very sick and it's like a pendulum. You can go from one side to the other side pretty quickly. So we have to keep a very close eye on it. So in nutshell, are there any pitfalls that can derail our VAP process? Yes, leaks, 10 times out of, it'll be 8 times out of 10 that you will have that issues. But then again, starting your settings too low can also cause that. If you don't have enough room and you don't have some room above what the patient is requiring, that can also set you off. And knowing your devices, knowing the variables, knowing what they mean, and knowing your goals for your patient based on their physiology are very crucial. Okay. Um, I do have some bonus slides. I don't know if we have time for it. I like to decide that, but
We have 10 minutes. I don't
yeah.
see any questions yet. So maybe we could go through some, unless anybody has any question right now. Maybe we can leave 5 minutes for questions.
Oh, yeah, I should be done by then.
Okay.
So I find this table very helpful when these patients come to us and in our clinics. These are just basic questions that you can ask, and it'll help you troubleshoot your ventilator very nicely. Whether so they are like basic 5 questions. Does the machine comfortably trigger a breath every time you want it? Which is basically telling you, do you get a breath? And you can change your trigger sensitivities based on that. Now, does the machine sometimes trigger a breath before you want because it's a very uncomfortable sensation that can happen? So again, changing a trigger sensitivity will help you in those situations. Then the third question is, after you start a breath, does the airflow in too fast or too slow? Because that will help you change your rise. And these are just the comfort things that you can add and ask your patient to make their compliance better. The other one obviously is, are your breaths too small or too big? Because is there a cycling problem or a TI time problem at that point of time? So these are some of my helpful tools. I ask my fellows to always ask those questions in our clinic, and invariably you will find something somewhere which will help you improve your compliance. And the same France group that I was talking about from Jose Gonzalez, this is an NIV questionnaire that we have started using in our clinic. This is a 11-point questionnaire, which I find helpful. It kind of gives you a breakdown, which hits most of the important points you want to know and address in your NIV clinic when they're coming for follow-ups. So this is like, are you suffering breathing problems when eating? Have you had headaches? Waking up with difficulty breathing? Are you often short of breath, trouble speaking? So these are just an assessment on those patients from neuromuscular standpoint as well. So I find this helpful. I put the reference here so you can look into that as well. I don't have any patient on Louisa. This is just, I wanted to show you because I went through each and every ventilator download, how they look like. So this is how a Louisa download looks like. It's a bit different. And remember, we don't have the cloud capabilities on it, so it has to be USB. I don't have any patients on Louisa, but this is what a Louisa download looks like. Okay, that's all I have for today. Thank you so much. So I'll stop sharing my screen, or I don't know if somebody has questions.
Yeah, thank you. Thank you so much, Ashima, for this detailed and excellent, thorough presentation on this really complex topic. I have a question, but I see a question here, and then maybe I can ask my question. This is from Daniel McNally. A very nice presentation. Thank you. 2 questions. One, I assume the study showing accurate data from flow and pressure sensors in the bilevel devices were done with new and or well cared for machines, have you seen problems if the sensors go out of calibration over time? That's one question. Maybe you
Yeah.
can answer this and I can.
Um, I think that is obviously that's a concern in some of these times. I have not personally seen it, but whenever but our ventilators are going out for servicing, I think every 6 months or so, and I think that is when they're looking at the pneumotac and making sure those things are not failing. But that is a very valid point. That sometimes if everything looks great and the download looks crappy, that will be one thing we should keep in mind. That is that contributing to it.
Yeah, that's true. Number two, when a device reports unintentional leak, I think it's making an assumption about the intentional leak and circuit compliance. How much
Yes.
difference is there in the reported leak from one machine with different manufacturers, mask and
Um,
service? And have you
that
seen?
is that is a very important thing. It is making all those assumptions. That's why if you remember my table, the total leaks that falls under a good assumption category. But when you're talking about unintentional, it is slightly off. I think I can go back to that slide. Where was it? I think I have to go on slide shows my animation here. So it's falls under the acceptable category because of that assumptions. And now, as I mentioned before, you have to remember there is issues with interface. If that's not accurately entered, that can also mess up your calculations of the leaks. And that's how your tidal volume estimation can also go off. So those things have to be kept in mind. It's just the total leaks which will be more accurately measured. The rest of the measurements will be a bit iffy.
I think it's 24 per liters and 60 per minute when you
Yes, yes,
somewhere
yes,
around
yes.
that.
So 95th percentile will be closer to 24 liters per minute. Again, that's if the interface is not accurately entered, those calculations will be all messed up.
Thank you, Oshima. I don't
Uh,
see any question. I had a question. So, now that the trilogy is going away, when you're transitioning from trilogy to Astral or Brios, you haven't done Louisa. Is there anything that you look at in particular when you're just making that transition from one ventilator to another ventilator?
In all honesty, I think the most accurate part will be I have done more astrals. Brias, I had started doing few years ago.
Yeah.
Somehow patients with Brias have tend to like them. It seems like it responds better to their comfort levels. The comfort features are slightly better. The leak compensation does help sometimes. But transition between Astral and Trilogies, I've been doing that for a couple of years. I think sometimes they do mess up with the alveolar ventilation calculations that I have seen notoriously happen. But since the IVAPS calculator is more freely available, I think those have gone down. But I haven't had much transition problems. And some of my patients who didn't like Trilogies or had issues with it, they seem to have liked Prius, just how it responds to them, the seamless transitions between one breath to the other breath.
Yeah. And when you're using the Astral, especially if they're in their, exacerbation phase and they have this high respiratory rate, how do you tackle that?
Uh, I think it depends. So we first of all we don't use astrals in our ICU settings. So once they have come out of the exacerbation, that's when I've been putting them on their Astrals or Brias or our V30s. So my first go-to is the V30s in those situations. And if their respiratory rate is that high, I'm like, I have to just sometimes switch them over to our regular V60s, control whatever primary process was, and then transition them because there is no way those machines will do anything if the respiratory rate is so high.
Got it. Thank you.
No
I have
problem.
a question here. Thank you. Very helpful. Some questions. Number one, how do you decide TI based on backup rate, respiratory rate, and or lung disease? And then that's from Parvati. Number two, if someone had a lobectomy, do you limit the tidal volume to less than 6 cc's or 6 cc's?
Sure. So the TI time, as we mentioned before, it'll be disease predominant. So for our COPD patients, I will keep a TI time maybe zero point 0.3 to zero point 0.6 at the most. For OHS and neuromuscular, they're very similar in my head, in the sense that I will be keeping for neuromuscular maybe sometimes I have to go up to 1.2 also. So it's like between 0.8 to 1.5, and similar to OHS patients. So the only exception with the COPD and maybe ILD patients. Now, as far as reducing the tidal volume, so I had a patient recently with it's called FST. It's fibromuscular dysplasia ossificans, something like that. And basically, what happens in those patients is they start having ossifications wherever there is any amount of injury. So Dr. Singh, in those situations, I have gone down because their lungs are so restricted and there is so much calcifications. I don't want to cause more lung injury. And I have tried to be closer to like 4 to 6 cc's in those situations. As far as lobectomy, in all honesty, and to be very honest, I don't have any patients like that on NIVs, but I'm assuming you would want to keep it lower tidal, don't want to cause lung injury in those patients, just blasting them off. But I don't know if anybody else has any input about lobectomy patients. I don't have any, so I'm assuming you will be keeping it lower.
Yeah, I think I had one and I did do lower, and there was one pulmonary dysplasia too that I did use lower
Yeah,
tidal volume.
yeah.
Yeah. I don't see any other question. If somebody has question, feel free to unmute yourself too. Um, as we were talking offline, Ashima, so how are you guys tackling this problem of home mechanical ventilator being prescribed, without any physician, just by social workers, and, you having to, come back and see this patient in weird settings without any downloads or
So Suri, like we had that problem definitely 5, 6 years ago, and since then I had had multiple meetings head-ons with RTs and social workers and our chief and IV people and all, that this cannot happen. I will not be responsible for these patients. So I think it has been a part of our education to the social workers, honestly, having meetings and being their direct correspondence for some time. So once that workflow is established, I think they tend to stick to it. The second thing was doing grand rounds and having everybody on the same page. I think that really helped for from people from medicine to, so I'm like all of them coming in the same background and understanding and discussing at that point of time. So just having the multidisciplinary meetings and grand rounds, I think have helped. I won't say the problem has gone out completely, but now at least they know that if this patient ends up in my clinic, they will be getting a feedback about it. So I think it had to be very proactive. I had to get very proactive because I'm like, I cannot be responsible for this, that transitions that didn't happen properly. So I think it has been, examples really helped, giving them live feedback very quickly in short time span, and giving them examples with MRNs and emails. So just reinforcing it again and again. It helped. Has it eliminated everything? Not really. There are new social workers that come along. There'll be
right.
new attendings that will come along. But I think those were 2, 3 things we had done proactively.
Yeah. Got it. Oh, that's very helpful. Thank you. Yeah, we've
Uh,
had multiple discussions with the social work, but we haven't gotten there yet. So,
it's very hard to get them on the same page.
yeah, no, thank you.
Problems.
I don't see any other questions, and it's exactly 3 p.m. So thank you so, so much,
No
Ashima. It's
problems.
such a
It's my
complex
pleasure.
topic. You've done such an excellent job. Thank you again, and thank you.
Thanks for having me. Take care. Have a
Thank
nice day,
you.
everyone.
Thank you,
Bye.
everyone, for joining in. Bye-bye.